Medical treatment of fibroid. First question, why medical treatment? Because there is high rate of recurrence even after surgery. It may be added to surgery, adjunct to surgery. Third, complication of surgery is a lot, even if it's minimally invasive, and a lot of patients don't prefer to proceed to surgery or surgical option. More accepted by patients, sure. More accepted to take medical treatment rather than to do surgery and exposed to anesthesia. Suitable for patient near menopause because it cover a short period till reaching menopause and then atrophy, natural atrophy of the fibroid occur. What is the ideal medication? Unfortunately, we didn't find until now ideal medication. To reach ideal medication, it should be curative rather than suppressive. Not should be permanent, not temporary. Long-term use should be safe and affordable, has no or few side effects. Non-contraceptive nature. Unfortunately, most of the drug has contraceptive nature, not teratogenic, inhibitive growth of already existing lesion, and also should be abort the development of new lesion, and also acceptable side effect. Here we revise the option for treating fibroid or myoma. All of us know that surgical hysterectomy or myomectomy, non-surgical conservative intervention like uterine artery embolization, but still intervention focused ultrasonography or focused energy radiofrequency myolysis. Lastly, medical treatment which is preferred by the patient. Medical therapy role in fibroid or myoma. First, to treat symptoms until doing surgery, to postpone or avoid surgery when circumstances become suitable for doing surgery, or even avoid surgery if the patient hears menopause, to prevent recurrence in women genetically predisposed to develop myoma as prevention if the patient highly susceptible to have myoma or fibroid, to prevent recurrence, especially in those who have high risk like young age or family history of myoma. First drug or promising drug for using during fibroid. All of us know the injection, GnRH agonist or antagonist. But what about oral drug? First promising drug was selective progesterone receptor mediator urobristal acetate sperm. One of the sperm selective progesterone receptor mediator. Second orally active GnRH antagonist rather than injection اللي هو معروف elagolix. Less effective drug زي SERM selective estrogen receptor mediator aromatase inhibitor, and lastly natural or vitamins like vitamin D, green tea extract. We will discuss everyone in details. First, selective progesterone receptor mediator. It is a new drug and has a lot of application in field of gynecology, like use as emergency contraception or use in contraceptive field, can be used in treatment of the fibroid. The most common or most famous urobristal acetate. There is mifepristone, which we used abortifacient, also azopresinil. This is the three most famous one of the sperm. What's the effect fibroid? Direct effect on fibroid, reducing their size, because progesterone promote proliferation and induction. So the sperm prevent proliferation and induction of apoptosis, or effect upon endometrium, making them stop uterine bleeding, or effect through pituitary by inhibition of gonadotrophin, so inducing amenorrhea. Urobristal acetate inhibit proliferation of the culture myoma in vitro and induction of apoptosis programmed cell deaths. Only sperm approved as medical therapy in myoma in Europe and Canada. The reduction reach about 35% of size of the myoma. However, the worry about their serious love injury not occurring cases, but there is case report of this, and 4 cases required transplantation is unfortunately a very bad complication which limit its use still now. Mifepristone. Mifepristone, all of us, there is long-term use of mifepristone as abort efficient, so it's used as for medical abortion. This is increased safety for its use to treat myoma. Azopresynine, but most clinical trials stopped because there is change in the endometrium and worry about endometrial hyperplasia and cancer because unopposed estrogenic stimulation. Sperm and endometrial change and unopposed estrogenic stimulation following period. This lead to second endometrium, histological change, but most of them reversible. When stopped treatment, this change will be disappeared. So it's preferred to use intermittent course, not continuous course. Use course, then stop course for 3 months, then return to another course. So here, this is a diagram showing that the decrease in size of the myoma after one course about 38%, after second course about 50%, after third course myoma decreased more than 60%. Second group of drug, orally active GnRH antagonist instead of using injection, which is expensive and maybe unacceptable for the patient, like elagolix, the non-peptidic orally active, so it's not distracted by GIT. It leads to rapid suppression of gonadotrophin, so it decreases heavy menstrual bleeding, so the presentation of the patient by bleeding stopped. Like it's not suitable for patient complaining of for infertility, have fibroid, and its main complaint infertility and want to conceive. Still in phase 3, the trial as regard the treatment of myoma. Sure, GnRH antagonist problem is continuous use, hot flashes affect على البون and osteoporosis, so it's not used more than 6 months and should be stopped. Intermediate. Selective estrogen receptor mediator. Lower estrogen in proliferation has no effect in proliferation of myoma, but it permissive. It enhance effect of progesterone to do proliferation. So if when block estrogen, block its effect to enhance progesterone. Effective serum is still unclear and less effective than sperm. Aromatase inhibitor. Better result occur in African American population than white races, still bad effect unsatisfactory comparing GnRH antagonist or sperm. Non-hormonal treatment still under research, has the advantage of few side effects or no side effects, زي vitamin D, curcumin, and green tea extract. Vitamin D deficiency, sure, all of us know that it's a risk factor for development of myoma. Thanks a lot.